All right, welcome back to part 3 for the EOR rapid review. This is based on the surgery PAEA topic list. Make sure you try to answer the question before the answer pops up, just so that you practice that active recall that we all know and love with our studying. All right, what is the most common cause of secondary hypertension? So your patient's on multiple different hypertensive medications, they might be young, no other real cause, but why would they have hypertension? Mainly thinking of secondary reasons. And the answer is going to be some type of renal parenchymal disease, renal artery stenosis being another issue as well, kind of goes hand in hand, but the parenchyma talks about like the actual kidney tissue being hypoperfused, and that sets off the RAS system. What are the colon cancer screening guidelines for a patient whose parent was diagnosed? So you're going to do age 40 or 10 years earlier than the parent, whichever one is earlier. So for example, if you have a patient whose parent was diagnosed with colon cancer at 45, then you would start at 35. What is the lifetime risk of a cancer patient? What is the lifetime risk of cancer in the liver for a patient with HCV? That's hepatitis C. So their risk of liver cancer is going to be 5%. What is the first-line treatment for an older patient with Graves' disease? So we're thinking elderly population with Graves. So we're going to do radioiodine therapy. And the reason why, if we look back at our thyroid axis, we know that TRH comes from the hypothalamus, which then acts on the anterior pituitary to then release TSH, which acts on the thyroid gland, and specifically activates the colloid cells or the colloid within the follicular cells that releases thyroglobulin, which then will release tyrosine, and then iodine helps for the co-transport and oxidization of the iodine to then create these MITs and DITs, which then turn into T3 and T4. And remember, T4 is the one in circulation, usually higher values. That's kind of the one we measure. And then T3 is the actual active thyroid. But if we use radioiodine therapy for someone with Graves' disease, they have a hyperactive thyroid. And so that way we will inhibit this iodine synthesis pathway for the creation of thyroid hormone. Okay, what is the most common cause of tricuspid regurgitation? So it's going to be right ventricular dilation. So if we think about our heart, I always like to use this little mnemonic, TP over MA. You can use whatever you want. I usually go with toilet paper meets anus, or whatever word you want to use there, but tricuspid and then pulmonic are both on the right side, and then mitral and aortic are technically on the left side. And so if we're having tricuspid regurgitation, that would be between the right atria and the right ventricle, where that tricuspid valve is flowing backwards. And so if we have that right ventricle dilating, that's going to cause the blood flow to get pushed back through the valve up into that atria. So that's the most common cause. What medication combination helps reduce new polyps that form in patients with colon cancer? So we can actually use aspirin or COX-2 inhibitors. Both of these at the same time. Aspirin and COX-2 inhibitors. So that's ASA and aspirin, and then your COX-2s are like your NSAIDs, ibuprofen and stuff. And so that can be used to help reduce polyp formation. What condition is seen in smokers with proximal limb weakness? So they can get this Eaton-Lambert syndrome, which is a paraneoplastic, and it mainly affects just the proximal limbs. There's other types of tumors, there's Pankos, things like that, but just remember the Eaton-Lambert syndrome is very specific for the proximal limb weakness. Which endocrine disorder is associated with complete molar pregnancies? So this can be hyperthyroidism. Patients that have hyperthyroidism, say like your Graves patients, they might have molar pregnancies, complete molar pregnancies. So which beta blocker can be used to inhibit the peripheral conversion of T4 into T3? So just remember that T4 turns into T3 at the tissue sites, and this T3 is acting throughout the entire body. Every process is involved in some way. So which beta blocker can actually inhibit this and be used for treatment of hyperthyroidism? It's going to be propranolol. Propranolol is also used for anxiety and things like that. So I always think of that one as kind of your diverse beta blocker that we can use for this. So what is the next step in treatment for carpal tunnel that is refractory to conservative measures? So that's when we go into the corticosteroid injections. Conservative measures are going to be rest, maybe some physical therapy, some stretching, splinting at night, stuff like that. We do want to be conservative when we approach our cortisone injections, just because we know that they can actually weaken the ligaments and things like that over time. But if these patients are severely impaired, it would make sense to look into that as an option for a local steroid. Don't give them systemic steroids for this. What condition has a palpable thrill over the right second intercostal space? And that's going to be our severe aortic stenosis. A thrill is really basically the turbulent flow of blood. So with stenosis, we know we get like that rumbling sound. And if it's severe enough, it'll become a thrill, which is almost something that we can inevitably assume is associated with severe aortic stenosis, and then always know when we auscultate, anything on the right border is typically going to be aortic valve issues. So if you have a patient with Addison's disease, which electrolyte is going to be affected for them? So they're going to be hyperkalemic, but hyponatremic. And the reason why is because with Addison's disease, if we think about our adrenal axis and the feedback mechanism, if someone's adrenal glands are producing very low cortisol, their ACTH is going to be very high. And so this kind of explains most of the processes. But what we also have to think at the adrenal glands is that they're also going to be affected in terms of what it is that the other levels of the adrenal glands. So remember, they participate in the stress hormone of cortisone, and then like glucocorticoids, so your sugars, and then your androgens for the sex aspect. And so your adrenals are in charge of all of those, salt, stress, and sex. And then when we think of aldosterone, the main mechanism based on how the RAS system works is it acts on the distal convoluted tubule to reabsorb sodium and excrete potassium. But since patients that have Addison's are low in their cortisone, you need to add the cortisol, they're going to have issues with their aldosterone as well. And so they're going to have more excretion of sodium and more reabsorption of the potassium. So that's why they're going to become hyperkalemic. How does lipoprotein a increase coronary artery disease? So it competes for the binding site on a plasminogen receptor, and that can influence the elasticity of the veins and the arteries, as well as specifically in the heart, which can lead to atherosclerotic changes. What is a common complication with levothyroxine? Osteoporosis. That's probably going to be the biggest one. Patients are on long-term levothyroxine. We need to think about why they might develop brittle bones, and it's because the thyroid hormone actually can stimulate the osteoclast activity, and osteoclasts, they cleave CL, and so they're going to break down the bone. Remember, your osteoblasts are your builders, so they're going to build up the bone. But instead, we're getting an overstimulation of the cleavers. What diagnosis is associated with recurrent calcium oxalate stones and UTIs? So medullary sponge kidney. Another one might be hyperparathyroidism. That could also be related. What is the most common cause of immediate post-op hypoxemia? And that's going to be atelectasis, which when we think about our wind, water, walk type stages, the wind is going to be probably related to the intubation and things like that. And then reduced lung compliance, and then those alveoli can actually collapse, and that can cause post-op hypoxemia. What are the two most common causes of 1 to 3 day post-op hypoxemia? So I kind of gave it away with the picture that I had in the last slide, but we're going to be thinking water at this stage. So things like pneumonia or pulmonary edema. What is the most common cause of hypoxemia on days 3 to 5 post-op? That's going to be our walk, which is our pulmonary embolisms. What causes Addison's disease? It's going to be autoimmune, autoantibodies attacking 21-hydroxylase. So just know it's an autoimmune condition that causes super low cortisol. What is the most common cause of hyperparathyroidism? It's going to be a parathyroid tumor. If we're thinking the most common cause of hypoparathyroidism, it's likely due to a extracted thyroid gland where they took too many of the parathyroid glands because they're on the posterior side, super little. You're supposed to have 4 of them. But if we develop a tumor there, that's the most common cause of a primary hyperparathyroidism. So what is the most common cause of secondary hyperparathyroidism? And that's going to be chronic kidney disease. So when we think about how the kidneys are going to be involved is your parathyroid has these chief cells in it, which then secrete PTH. And parathyroid hormone can act on the bones to increase bloodstream calcium by increasing the osteoclasts. It can also act on the kidney, which allows for the active vitamin D to be used from the action of calcitriol. So PTH is in charge of monitoring that. And the more calcitriol you have, the more calcium you're going to reabsorb. But if we think with chronic kidney disease, that kidney is not going to be producing the calcitriol as much as we're thinking it should. So that's going to leave the calcium levels pretty low because calcitriol is not reabsorbing at the small intestine and reabsorbing into the bloodstream at the distal convoluted tubule. So at that point, it's likely ramping up the PTH. So the PTH is going to be really high, but they're still going to be having the symptoms related to lower amounts of calcium. And then for labs, always consider that we need to check their albumin because most of calcium, I think it's about 80%, is actually going to be attached to albumin as kind of its protein carrier. So if you have low protein, low albumin in the diet, your calcium will be affected by that value. And so make sure that the albumin is not out of range. So if a patient is diagnosed with squamous cell carcinoma, which 2 things are likely in their history? Asbestos and smoking. If it is just asbestos, we're thinking more mesothelioma, but if it's both asbestos and smoking, that puts them at higher risk for squamous cell carcinoma. What diagnosis is going to be associated with cavities in the lung apices? So this is tuberculosis. Lung apices, don't get confused. The bases are down near the diaphragm, and the apices are actually up at the top. With your heart, it's the other way around. The apex of your heart is actually closer to the diaphragm, and we don't really talk about the base of the heart as much, but just remember, TB likes to climb to the top. If a patient has super high calcium, what are you going to expect their phosphate to be? So that's going to cause their phosphate to be low. I think of calcium and phosphate on this teeter-totter, calcium high, calcium high, phosphate low, and then calcium low, phosphate high, and that's because of the relationship as in terms of how calcitriol works. I almost think of how calcitriol and aldosterone are similar in the way that they have that inverse relationship. Aldosterone reabsorbs sodium and excretes potassium, whereas your calcitriol is going to reabsorb calcium and excrete potassium. And that's all for now. Don't forget to subscribe, and I'll see you in the next one.